Good evening. Thank you, everybody, and welcome. I appreciate everybody who's able to be here. So, the COVID-19 pandemic has brought unparalleled challenges for healthcare in the United States and in Northeast Ohio, with many still working tirelessly to coordinate care for patients struggling with opioid use disorder, all while navigating disruptions and lingering effects of the COVID-19 pandemic. These unique challenges created precarious scenarios for providers and patients who have led to adopt new strategies to deal with the uncertainty of the pandemic. The Northeast Ohio Hospital Opioid Consortium, a hospital system based and physician led collaboration housed at the Center for Health Affairs, is giving attention to this issue by hosting this virtual town hall with experts in various ends of the continuum of care model. These thought leaders will discuss the path forward, how the pandemic has reshaped care, and provide tips and resources for members of the community who are struggling with opioid use disorder or have people close to them who are struggling with the disease. This is the second time we've done this event. The first one was all the way back in December 2nd of 2020. So if we think about where we were back then versus where we are today, it feels very different, but imagine, kind of where we were and think about all the different things that have changed and impacted. And it's going to be an exciting conversation to be able to have, to think back about what it was like before, what it was like in December of 2020, what it was like all the way along the way, and what it's like today. So today, I'm going to let the panelists introduce themselves, and we can start with Anna Whitmer.
Hi, everyone. My name's Anna Whitmer. I am the Medical Director for Addiction Services over at Signature Health.
Thank you. And then Kim Eberly.
Hi, I'm Kimberly Eberly. I'm the Executive Director of a recovery community organization called Let's Get Real, with two offices, one peer center in Lorain, Ohio, and one peer center in Norwalk, Ohio.
Great, welcome. And then Dr. Chris, I don't know if your mic's working. We're going to try.
I hope it's working. Can you hear me? Oh, shoot.
Yeah.
Hi, everybody. I'm Chris Dellis Reyes. I am an addiction psychiatrist on the staff of University Hospitals, Cleveland Medical Center.
Great, thank you. And I'm your moderator tonight. My name is Aaron Marks. I'm a member of the recovery community. I've been in recovery for over 17 years from opioid use disorder. And, I am the president of the board of Stella Maris, as well as I am the chair for the prevention and education subcommittee under the U.S. Attorney's opioid task force. So very excited to be here. And we're going to just jump right in. Again, thinking about what we talked at the beginning, kind of how have you each seen the coronavirus pandemic impact kind of the overall opioid crisis, as well as your agency's ability to kind of combat the issue? And anyone can jump in first if you'd like.
I think as a person in recovery myself, and I've noticed, as we all have, I'm sure on the panel, just a huge influx of relapses, if you will, call them whatever you will. The isolation factor is huge. Not being able to attend not just 12-step meetings, but as a recovery community organization utilizing peer supporters, we have a no wrong door approach to recovery. So I'm not talking about just 12-step support groups. I'm talking about church. I'm talking about the smart recovery model, whatever that would be. Just the whole isolation fact in its of itself increased our numbers as to those seeking help for detox treatment, things like that. We're a huge referral source for those, a navigation system for connecting with detox treatment, sober living, whatnot. It was not good. It was not good, and it had a longer effect than I foresaw.
Yeah, no, that's a good point. And I know, again, also being in the recovery community, there was this emergence of things like Zoom meetings and people trying to get creative. So how do you think, kind of two parts back to that. So like, how do you think that was a stopgap for a certain amount of people that did provide help? And then also, like, how do you see that impacting kind of an entry point for people into recovery moving forward?
So I can say when everything first started, it was like the rug kind of got swept out from underneath us. So it was essentially overnight. We went from in person to everything was virtual. And so, yeah, we did have to get creative, but it did cause a lot of, barriers for patients. We had, they no longer were going to groups, their meetings were canceled. And so, we had to get clever in how we would do this. Our agency did a pretty good job. Within about a week, we were able to get groups back up and running through phone conference. But if you ask patients, that was not preferred at the time, and it still made things difficult for them. Um, and then just thinking patient wise too, when you essentially close your office to having patients come in, you're relying on technology that patients may not have. So people didn't have telephones, or if they did, they only had a certain amount of minutes to utilize, or didn't have internet. And so it caused even more of a isolation for them. Um, I will say though that telehealth has been actually over time become a pretty good thing, because it has increased access to treatment for our patients, just as far as the ease of them being able to do it. Some of them still prefer to come in, but it also gives the opportunity for people who have full-time jobs or have a family and they can't get in. So in that respect, it has been a good thing.
Yeah, I would echo.
I know that we're active in specialty dockets, I'm sorry, go ahead, Chris.
Oh, I was just going to say, I was just going to echo what you guys said. We also had that, I can still remember it. It's kind of like PTSD burned into my brain. Like one day, I think it was St. Patrick's Day of 2020. And then suddenly that day was the last day I saw patients in the office for about 2 months. And then I quickly went into a hybrid mode and spent the last 2 years seeing Zoom patients on Tuesdays and live patients on Wednesdays. And so my life just became this sort of weird mix of, I still came into the office every Wednesday, but, I was staying at home the other days of the week. We tried out many different platforms. We went to Zoom and then we picked other ones and then we went back to Zoom. So there was always something going on, glitching with the technology. So I definitely remember that. And yeah, we also had similar struggles. If you don't have a phone, if your internet connection is really bad, then what are you supposed to do? I feel like the biggest struggle, and it still is a struggle, is just trying to get urine drug screens on people that are not showing up to the office. And so it's just a lot of chasing people around and, trying to find them the lab, and then the lab is closed because of COVID, and round and round and round in circles. I think that Zoom is, like most things, it's a double-edged sword. I mean, there's parts of me that really, really hate Zoom, but there's parts of me that really like it as well. So yeah, I've tried to look for the silver linings, but I'll tell you, I've really enjoyed getting back to the office more days a week and actually starting to see more people in person. I just think it still makes a huge difference. I also attend Al-Anon twice a week, and when the meeting shut down, that was horrible. We had these crazy hybrid meetings, and then I even had one of my home groups split into 2 different meetings. So we have this Saturday morning group, and half of us meet by Zoom and half of us meet in person. So it's kind of very strange. So I don't know what's going to happen, but that's kind of the current state right now. So.
Yeah, we're active in specialty dockets, which is recovery courts, in 4 of them in Lorain County. And sorry, I'm kind of a direct speaker. I'm trying to be. It's a nightmare. It was a nightmare to try to have 30 court participants on a screen for court with whatever honorable judge is there and the rest of the treatment team. And, through no fault of the participants, we're just jumping on for a court date with a t-shirt and we're smoking a cigarette. I mean, you're still in court. That was a lot. And I'm not faulting them. I'm not being negative. I'm just saying, and we would literally, my peer supporters who work in the project would literally text their peer, their participant, and say, do you really have a cigarette in your hand? It was just that adjustment to we have to treat this as the same thing. It was very difficult. Very difficult. And with our warm handoff project at the hospitals, because of we're blessed to have the relationship that we do with our hospitals that we go to 24 hours a day, 7 days a week, that call us for assistance for the patients. We were literally sitting in a parking lot, and the nurse would call and say, I think he's about ready to go. And they would try to answer the seven questions, just 7 out of 20 questions on our preliminary screening to see where we would maybe take them. And then we would pull up and they would let the patient out to get into our car to drive them to detox. It was not good. 2 different times they closed us down completely, again, through no fault of their own. Hospital administrator said, no peers are coming in here. And that had a huge effect. The heck with us. It doesn't matter for me and my peers, my peer supporters. What mattered is all those people that weren't being seen and that we could have served by getting them immediately, honestly, into Stella Maris, wherever, we could have done that. And then once in that crisis mode, if you don't strike when the iron is hot, as everybody on here knows, and you get to walk out that door, the chances of me being able to I don't want to say convince, but to explain to you how easy it could be for us to assist you to get into the next towards your recovery, such as detox, was gone. I mean, you've missed that moment. Really difficult stuff. Really difficult stuff.
That's really interesting because, like, when you go around and you listen and kind of going back to what you said, Chris, kind of about this like double-edged sword, is that there's clearly some really some large gaps, right, that prevented people from being able to get treatment, from people preventing people to be able to get access in that moment as needed. But then you think about some changes. Like, I remember when we had this conversation in December of 2020 about like what's going to change, and it sounds like things like telehealth and access to care and access to meeting people where they are is something that may not have been able to get the level of traction it would have without something like the pandemic happening, right? So it's like, on one hand, there's these massive deficits, right? On the other hand, you're now having a whole different subset of people who are maybe you're able to access them for psychiatry or psychology or group therapy or things like that, where maybe you weren't able to reach them before. So it's, I guess, like, as we think about that now, how do we marry those things and create these like best of both worlds, right? How do we emerge from this and like take the lessons that we've learned and be able to maintain those best practices of this kind of new way of doing things while like pulling back the most important things that were maybe lost during the pandemic? I know that's a broad question, but like, let's brainstorm it. How are we going to do that?
You guys probably know the answer to this. You're the experts more than myself, but weren't there several changes to the telehealth requirements, for example, for HIPAA laws? Am I way off base here? I don't know what I'm saying. I remember it doesn't really honestly apply to me, but I remember reading all these, and that's kind of a good thing, isn't it? I don't know. Is it?
Yeah.
It's most definitely a good thing. So again, almost overnight, suddenly methadone could get delivered to your door, whereas before you'd have to show up at the methadone clinic 6 days a week. So there was definitely, and that continues to this day, a relaxing of the laws. If you were going to prescribe somebody Suboxone, you had to have that first visit live and in person, in the flesh. And that gradually dropped away to, you could do it virtually, and then it dropped down to you could literally do it by phone. So, so access, again, it decreased for a little while when the whole country was shut down. And then after the laws loosened up, the access started to increase. Although I will say I only started one patient ever by phone, and I felt very uncomfortable because I was talking to this person. It was a voice, had no idea what they looked like. I had no idea where they were calling me from. I only had to take them at their word about what they were using. I had no drug screen. I didn't like that, So, I mean, yes, I think it
Good.
works, but I don't know that I would want to practice that way, like continuously. And so again, I do think there's something to be said for at least a visual of a person, and then making sure that you can get labs and drug screens in a timely fashion. Not that you have to get it that day, but yeah, you should probably get it within 7 days, right? Like at some reasonable amount of time. But I know the technology is changing all the time. They now have breathalyzers connected to your cell phone that you can blow into, but they don't have something that you can pee into yet. I don't know what that would look like, but I'm sure it would be strange. But I know that the technology is always changing. So I think it's just staying on top of what are all the new technologies that are out there. So, yeah.
Yep. And we have the luxury, I should say, that we have RN care coordinators with us. And so they do get to see the patient on site, even if we are just a phone call. So they can set us up. That has actually been a great thing for improving access for us, because with the flexibility in these laws, we have been able to start something called a MAD access, which we did in collaboration with our ID team. And essentially, a patient can come in, get a diagnostic assessment. They're diagnosed with opioid use disorder. They see an RN. They do a full intake, get that urine drug screen, labs are drawn, Narcan education. And then same day, they will see that prescriber, and it may be by phone or it may be by, virtual, but they'll be started on Suboxone that day or next day. And so the relaxing of those rules allow that to happen. So hopefully that will continue. Otherwise, we may struggle to keep that going. But it's been a really great way to get people on buprenorphine quickly.
I mean, I think it brings up, and this is not pandemic related, but I think the pandemic has opened people's eyes. I've always been a person in favor of why do we even have to have an X waiver for buprenorphine, which I know is not something shared by every prescriber, but certainly for me, I was like, why do we have to have limits? Why do we have to take an 8-hour class, et cetera, et cetera? And so I don't even think that everybody in our audience may be aware that as of April of last year, so really a year ago, the laws were changed so that any prescriber doesn't even need the 8-hour training anymore. And they can prescribe for up to 30 patients. And so while I think that was great, I think it's kind of like too little too late, honestly. And I think they should have just gone all the way and got rid of the X waiver. Because if you think about it, we had record numbers of people die in the last 2 years because of the pandemic. And then they sort of loosened this up a little bit, but I don't think they loosened it up all the way. You guys may have different opinions on that, but that's just one doctor's opinion of like, man, we have not gone far enough in this country to do what we need to be doing about the opiate pandemic. So
I 100% agree. And the fact that they even limit it, like we have to have an X waiver, whatever, but don't limit the amount of people we can see, but also get rid of the X waiver. That would be fine. So.
Okay. Well, kind of on the same topic, but more, so you're kind of moving into this harm reduction conversation, right? So how do you see, like, what did we learn about harm reduction throughout the pandemic, right? So like the numbers have gone up, right? We've had these great programs and these great, initiatives between fentanyl test strips, naloxone, various education campaigns. So there's been a lot of attention towards it, but clearly we found we see some gaps, right? And so there's still some room to kind of push things forward. So like, what are those gaps that have emerged that the kind of pandemic shined a light on? And where do we kind of need to take those harm reduction conversations next?
We have a harm reduction clinic in Lorraine. And we meaning Nord Center and Let's Get Real is a part of it. And there's a lot of us. And during the pandemic, we were in the middle of flux, geographical location change, but still in the midst of that, it was, everybody's sitting there thinking, this isn't going to happen. This isn't going to happen. And just since things lifted in the pandemic, I don't know where the pandemic went because I'm afraid to say it's gone but anyway, as soon as that kind of lifted, then we saw this resurgence of people coming into the clinic that was stronger, more volumes than it had ever been. And I think that clearly, for that type of intense, if you will, clinic where there's a needle exchange, clean needles for use, dirty needles, as well as a safe using kit and things like that. The only way to do that clearly is for them to be there physically. So, I mean, there's no other way. How else would you do it? We're not going to mail them their syringes and ask them to mail back 5 dirty ones. Okay. So it seemed like, oh, okay, the pandemic time, it took a break. It's taking a nap. I don't know. So and you immediately saw those numbers rise. And it was just such a relief. And just the whole not having to have the mask on. I don't know about you guys. It is really difficult to read somebody's feelings with a mask on. I mean, I don't know what they're thinking. I don't know what they're feeling. I don't know if they're mad that they're there. I don't know if they're buying into their thoughts of recovery. I can't tell with the mask on. That was very, very hard. And quite honestly, we misread several engagements because all you could see is people's eyes. And then we would find out later in our beginning progressive steps towards some sort of recovery, some sort of plan, that they weren't buying it at all. And that's hard. That was hard to read, especially with masks on. That's all I can really speak to is to harm reduction is the relief when finally it had lifted a bit where no one was masked and things like that. I know that well, I don't know. I'm going to stay on harm reduction. I tend to go south for anybody who doesn't know me. You got to say, Kim, focus. We're talking about harm reduction.
Yeah, we will have plenty of other topics to talk about, I promise.
Yeah. I mean, again, something that has been covered in many different venues is the how the pandemic sort of shined the light on structural racism, right? So you started to see more people in communities of color dying of overdoses than in white communities, etc. Fewer people with access to life-saving medication in poor communities of color than in other communities. So I think that's a huge thing. I mean, it wasn't only the pandemic. It was the pandemic plus George Floyd plus you just add on and add on and add on. So it's been a really, I don't know, traumatic 2 years in a lot of different ways. And again, double-edged sword. Now that this stuff is sort of wide open, I mean, obviously people have been struggling with this. It's just that it's now being noticed. And so now that we've noticed it, what are we going to do about it? So again, I think reaching out to those communities, that just becomes, again, more and more important, making sure people are aware of Narcan kits, Suboxone, methadone, etc. But again, there's such mistrust of the system, understandably. So I think you're trying to overcome just a whole range of different obstacles. And one of the biggest ones is just mistrust of the whole entire medical system, which again, that's not something you're going to fix overnight, but slowly, things are creeping along and starting to change in that arena. So if anything, I've myself become more aware and have gotten more involved with diversity, equity, inclusion type projects. And I think that's all good. So I'm hoping that continues even past this pandemic, because it needs to, quite frankly. So I think that's one of the big, takeaways.
Yeah, I think the pandemic also helped us as an organization to kind of see what we had been doing, because I mean, it really flipped our program like a complete 180. Prior to COVID, patients were coming in 3 to 5 days a week for group. They're picking up their Suboxone with group. They're doing urine drug tests like 1 to 2 times a week. And then COVID happens and people are picking up 2 weeks of medications, um, you know, attending what they can attend. And um, gosh, urine drug tests really diminished because we didn't want people in the office, and we wanted to keep them safe. So we were able to kind of reflect on this a little bit and think, where do we want to be as an organization moving forward? Because we now have gone on two extremes. And we really wanted to start thinking about being more patient centered and providing that patient centered care and meeting patients more where they're at rather than what we think they should be doing. And no longer are the days where if, after so long they're still struggling with sobriety, we're not sending them off to residential, and then not go, and then they overdose and die. We keep working with them because buprenorphine, I think as long as they're on it, there's a 50% decrease in risk of overdose. And so stopping them actually puts them like 3 times more likely to overdose. So we focus now more on retention in our program and trying to just work with the patient rather than having them more like strict programmatic adherence, essentially. So,
Are you saying, Anna, that your program philosophy actually changed as a result of the pandemic?
it was yeah, it took a while. I mean, it's hard when you're changing. We changed our culture. I mean, so we did a lot of engagement with our employees. We did something called Mat Champions, where monthly we would be speaking with our employees and kind of helping promote this patient-centered care, trying to work on getting them motivational interviewing skills, things like that. So that way, um, it was a little easier. There's still struggles, but it's come a long way. So
I'm curious. I'm just thinking out loud. It's another question, around the same thing, which is like, it sort of felt like maybe we were moving towards that anyway, right? Like this kind of expansion of MAT and like really focusing on a lot of the data that was coming out of studies. And like, so do you think that the change that your organization underwent was an inevitable change that was like sped up by the pandemic, or do you think it was more of a result of kind of what you noticed in the pandemic?
I think it was an inevitable change. I know our chief medical officer was very much, she was very passionate about moving towards more of a patient-centered kind of harm reduction model. The pandemic definitely sped it up because it forced everybody who had anxiety about moving towards, not only having urine drug screens as a tool and, the pickup of medications and just being more flexible with patients, uh, definitely was just kind of thrown at people and they just had to accept it for that period of time. So I think it helped kind of move it much quicker. Yes.
Okay, very interesting. So
Hmm.
so thinking about kind of where we're at today and these changes that we've talked about, like what kind of resources and programs and kind of intervention points should the community know about, and like how can they direct people who are suffering with opioid use disorder to find care in today's world?
I mean, I think you're still.
I think
There's
it's networking,
Yeah.
Go ahead, Chris. I'm sorry.
Oh, no. You go. I'll go after you.
I think we're different because, well, you know what we are. We're a recovery community organization. We navigate people towards providers that are shown on the screen. That's what we do. We don't make clinical decisions, but we have a template, if you will, that works well in navigating to other providers and taking an educated guess as to who that provider might work for them based on insurance. We know what provider for detox or treatment or whatever takes that insurance. We know who doesn't take Medicaid. So I think in part, this being forced to communicate only on the computer and being forced to communicate only on the phone for us kind of strengthen that. You got to call them. You got to call them. You have to check. We can't even go there. We can't drop in at any of your places. So it helped my staff, my peer navigators at the outreach desk, for the callers off that call from the community. It strengthened that, and I can be bold enough to say that I feel that it kind of reconnected some different providers in, and I can only speak for Lorain County, that were kind of relying on each other. Well, hey, we don't have telehealth right here for that. And it kind of forced them, if you will, and this is a bold statement from me, to use each other. If this provider happens to have this telehealth in this state and you need this, then maybe you need to go there. And I think it's a great thing coming from what we do. It is a great thing. They were major changes, and I'm not going to say, and Anna, the stuff you were saying is amazing to me. It's great. Because we're always client centered and client choice. We're on a whole different plane than you guys, but I'm saying that's, we rely on assets of whoever we're dealing with, and their right to voice where they want to go and have a part of their recovery plan from beginning to end. So I think somewhat the pandemic kind of forced my, if nothing else, quite honestly, to get a little more training on computer and Zoom and phone, and it's a must needed have to do that should have been done anyway and was a necessity. So we were just kind of forced to do that. I think MAT influx, I don't even want to call that. Yes. I mean, it did. It was like, well, I don't really care if you're comfortable with this, because guess what? You are now, because this is all we have. So you're going to learn this. So it forced some strategies that should have been in place anyway. So that was a good thing. But I'm finding now that I'm getting asked to now supply my proof of COVID vaccination for myself and all my staff to providers now. And I kindly wanted to say, why didn't you ask me this 2 years ago? But now I'm doing it. So I think that's a little too late. But of course, we're satisfying that requirement for our memorandum of understanding in our contracts. But I just, it was like, oh, we have to hurry up and do this. Now we have to prove it. I went south there. See, you have to keep me in line, Aaron.
I'm sorry. Yeah.
I think I wanted to add two things, just technology-wise. I was just looking up a couple of websites. So there's something called drughelp.care. So it's drughelp.care. And it's a sort of a live system. Your agency has to join voluntarily and has to update the information daily. But if you update the information daily, then a person out in the community can go there and find out how many beds there are available at Stella Maris, how many beds are available at Rosary Hall, how many beds are available at UH. As long as there's somebody in the background that is updating it on a regular basis. They also have hookups for peer support. So I think that's a fabulous website, drughelp.care. And then the other one that I learned about recently is called, it's got kind of two names, but it's called the Neighborhood Navigator. So if you just type in the words Neighborhood Navigator, you will come upon a project called the Everyone Project. And this is a national thing where there are a list of 40,000 social services by zip code. So anywhere in the country, you can direct your patients to food, housing, transportation, employment aid, legal aid, and financial. And so once again, if your current agency isn't on the Neighborhood Navigator, you should get on it so people can find you. And if you want to help people find resources in your own community that you may not even know exist, just type your zip code into the Neighborhood Navigator and you'll get a list. So I just think that stuff like that, that technology probably was inevitable anyway. probably got sped up by the pandemic, but we have all of these things now that we didn't used to have. And of course, if all that fails and you don't have internet and you don't have a smartphone, you can always call 211, right? And then there's this talk that they're supposed to start the National Suicide Helpline is going to start. Is it this year? 988, is that the number? I don't know if you guys were aware of that too. So that's another huge thing that I'll be very interested to watch the rollout of 988 nationwide. So we'll see what happens. So, but it's kind of things like that that we need to continue to get out there in the communities and tell people you can get help 24/7, and these are actually, very, helpful ways instead of calling a phone number and the place is closed. If you've got these live updates, you kind of know how many beds a place has, so you don't waste your time. If the place has no beds, you go to the next one on the list. So yeah,
That's super helpful. Thinking about more resources, access to Narcan. So you should be able to go to pretty much any pharmacy to get that. But then also, if people don't necessarily want to go to a pharmacy and get it, so it shows through their insurance or whatever, there is a website called, I think it's called nextdistro.org, nextdistro.org. And you just watch a little video about Narcan education, and then they will send it to you in the mail discreetly, and it comes in a package. So they'll send you 2 kits. So that's a great resource. One thing, thinking about, what healthcare professionals could do too, and I found this useful, is when we're doing these telehealth appointments, it actually helps to give you a point of view of what's going on in their situation. So you finally see where they're living and where they're, what resources they have in their home, if they have a safe home. And so that way you can help link individuals to, caseworkers or whoever else that can help them access some of those things. So.
yes. On a lighter note, I've gotten to know a lot of my patients' pets through Zoom, and they've gotten to see my dog as well, because on the days that I work from home, I would show them my dog. Okay, dogs, cats, all those lovable creatures that help us get through the day. So that's been really fun. But you also do get to take a look in their houses a little bit to get some ideas about things. And I do remember that for my ladies that have been in domestic violence situations, they would often call me from a closet, or they would call me from behind a locked door, and they would whisper, and they would go, well, I have to talk really soft because I don't want them to hear what we're talking about. And so that was like a huge clue that they may not have been able to share with me in a live setting, but because they were in Zoom and they were at their house and they kind of felt trapped, I definitely, that came across very clearly, like, this person is clearly not comfortable in her house, and her abuser lives with her, and you get to see parts of that too, which is really sad. But again, then you can try to hook them up with resources if possible. So.
Great, thanks. Yeah, I've been trying to keep him out of the screen for the past 5 minutes. So just so you know, my hands are moving around trying to be professional here. So we've talked a lot about the things that have changed, the things that the flashlight shined on. So what are the things that the flashlight shined on that you feel didn't change, that we still need to say, okay, now we're seeing this so clearly, here's the rise in overdose deaths, here's like the lack of access to care. So what are those things that you kind of hoped would have changed from the lessons that we've learned from the pandemic that haven't?
Well, we still need better insurance coverage. We still need mental health and addiction parity. We still need to do away with prior authorizations every 90 days and just, begging for people's meds and them going without meds. So those types of things haven't changed. I mean, gosh, it was so beautiful in the first 6 months of the pandemic. I didn't have to do a prior auth on anybody because everybody just got them automatically. And I'm like, man, can't we just keep that? But then they, after about a year and a half, they were like, okay, we're going back to prior auths every 90 days. So, there are still things that I think we need to fight for our patients. And I think there's still, stigmatized illnesses by and large. So that hasn't changed a whole lot. I think it's gotten better, but it's still an issue. And doctors and patients tend to be uncomfortable talking about these topics. And so sometimes you just need some assistance. I mean, I've been grateful that there's been more peer support workers in our emergency rooms, for example, on main campus. That's fabulous, because then it sort of creates that, connection that that person needs to be able to get into recovery that wasn't always there. So I love that the peer support movement has grown, and I hope that continues. But again, those are things that need to be paid for. Medicare still doesn't pay for residential addiction treatment. So yeah, there's some hot ticket items that we still have to work on as a nation. So, but again,
yeah, I couldn't agree more. That's what I was going to say, Chris. I couldn't agree more with the stigma. I mean, some things just need to be boots on the ground, in your face, addressed. And that's one of them that I think the whole pandemic didn't help. I mean, not that we expected it to, but it just, you can't have the rallies, and you can't have the informative sessions, and you can't have everybody out there, physically out there, saying this is what we need to speak to, and address and understand. I don't see that was much changed, and also, neither was the inward stigma for people on OUD using different ways to stay clean. The inner stigma from those people from medication-assisted treatment to their peers that don't use MAT, which is such a dream of mine that it's never going to happen. But I don't think the pandemic helped us to step forward in an informative way and forward in an open-minded more way and be able to address those stigmas inwardly, from those in early recovery on. So yeah, some of the things the pandemic has not done well on, or I don't want to use the word stagnated. I think that's a bit dramatic, but certainly slowed down any forward moving progress. And I would say definitely it's family stigma that was one of the most affected for sure, as well as the family intervention and family help. I don't know that we've made any progress. We were slowed by the pandemic regarding family members and loved ones of OUD, SUD persons. We have a family group at my office. We've had 9 years every week with the children's group downstairs. Family members are upstairs. Doing that on Zoom. Come on. And that, so I did the meeting at the same time. So I have it open for Zoom, as well as the people there. And we were blessed enough as an agency to get one of those OWL systems that's a 360 on. You can plug in, and if you talk, Aaron, it'll go swivel to you in the circle. If I talk, it'll swivel to me. That helped with interaction, but yeah, definitely on the boots on the ground, getting in people's faces, maybe having rallies and giant talks as a community as a whole, that wasn't helped at all by this.
Yeah, I also wish Narcan would be just more normalized as a society, like that. Curing it doesn't mean anything except you might help a person that falls out at the gas pump next to you. So but instead we run into, we wanted to place Nalox boxes at places, and they're just like, nope, that's a liability. Or, you get this weird, discussion about it. And it's like, yeah, but people, it happens everywhere, and we can't have our heads in the sand about it, and we can save lives. And that's, the first step to recovery. So for that person, or the person that saves a person's life. So, yeah, I just wish that had gotten a little more normalized someday.
And some of it was lightened up a bit, as far as you have to watch the 20-minute video, then you sign this paper, then you get, 8 milligrams. Some of those rules and restrictions were lightened a bit, which was helpful. But I'm exactly with you. I don't know. We're a Narcan distributor in Lorraine as well as Norwalk, and nobody comes. Nobody comes. It's free. I market it. I don't know where everybody is, but some of the restrictions for obtaining Narcan were those not lock boxes or whatever you're talking about. We can't get those sold out here either. Sold being a loose term. I mean, they don't want them anywhere we've tried. I don't understand, but they don't. So I doubt that marketing aspect has been
People
served.
don't want them because they would have to admit that they have a problem in their community. That's why people don't want them. So
There you go.
Yeah. I mean, even my patients, when I offer them, I've got free naloxone in my closet right here, and I offer them naloxone, and they'll be like, well, I don't need it, Dr. Chris, and I don't hang out with anybody that's using anymore. And I'm like, yeah, but you have no idea who's using around you. That could be a complete stranger whose life you could save. And then they kind of go, oh, so some of them are convinced, but then I've actually had still some of my clients straight up refuse. They don't want to be associated with anybody that's using. They don't want to know. And it's like, wow, you've stuck your head back into the sand. Like, wow, that's pretty amazing. But, I offer every time, like, if you change your mind, I've still got the free Narcan kits here in my closet. So, it's that little by little that you just have to talk one-on-one with people. But there's still, and again, some of my clients have said, if I get stopped by the cops, I fear that I will get in trouble if I have a naloxone kit because it will be assumed that I am an addict. And I'm sitting here going, okay, so I have 6 Narcan kits with me at all times, falling out of my backpack. So if I get stopped, am I going to get harassed? I have no idea, but I don't care. I just carry them around, And so, again, that's that public awareness, public messaging. I don't know why you would harass somebody with a Narcan kit, but again, that's what my patients are telling me. Like, we'll get harassed, so I don't want to carry one. And that's unfortunate.
And some of the real giant message that needed to be, one comes off the top of my head, with the fentanyl and the carfentanil and the crazy, Lord knows what it is. Okay. Who knows what it is? Nobody knows what it is. You have no idea what you're using, but we all know that the Narcan, the half-life of that is not anywhere near the half-life of fentanyl. And we run into this all the time. No, we are not removing that person from the hospital for 120 minutes minimum, because we've had them fall back out, if you will, in our peer supporters vehicle and re-Narcan. We've done sternum rubs. So that kind of message was not helped by the pandemic. And I think we were beginning to push those safety measures in a public fashion prior to it. And then we just kind of went, oh, oops. So that was not helped by the pandemic. And it's another one of those that has to be just a huge public understanding and presenting it again, that this is great. Narcan is great. Please understand. You got to get somewhere safer. It's not, you have the potential. Even with the Good Samaritan laws way back when look where we're at. I don't know.
Well, and it's scary too, because you see, I was just watching the news, I think last week, where they were showing some of those pressed pills, and they are like Tylenol. It looks just like Tylenol. So,
yes,
it could happen to anybody. I mean, you ask a friend for an ibuprofen, and then all of a sudden you have no idea what you're taking. So, yeah, I just think everybody should have Narcan.
You think? Yeah. I mean, the pressed Percocet and fentanyl look the same. They look like Percocet to me.
Mm-hmm.
We've had several overdoses recently with those. Scary.
So how can somebody listening today, right? Or, maybe somebody who listens to the recording, or we get into a conversation with somebody and, they say, oh, naloxone enables people to use drugs or whatever it is. Like, what can we do to help kind of dispel that? And like, what can somebody listening do to help kind of chip away at some of that stigma?
So research shows
No,
that it
yeah,
isn't
the only
the
power
case.
we have is
Yeah.
education. They need educated. The only power we have is education and their acceptance of education, especially from family members. That's all we preach. You are not in control of any of this. You're not. The only power you have is in learning, you know. But I don't know. You go ahead, Chris. You were talking.
No, it was
Oh,
Anna.
I was just
It was Anna.
That's okay. I was just going to say that research shows that isn't the case, that it actually, people who actually use less when they have Narcan because they want to be able to help their friend or help someone else in case they need it. So there's that, and again, it can serve as for both the person it's used on and the person that is using it, a pathway to recovery, because someone's saving a life there, which is like one of the best things, a person can do to really improve their worthiness and self-esteem and things like that. And so it can be that step where, that they feel like they're able to get treatment and do more and feel better. So, but yeah, there's just no
See, that's your
evidence that shows.
positive statement. That is your positive statement. What the world hears is one tiny granule of negativity. That's what everybody remembers. And that's what everybody remembers forever, basing their entire life on it. So the negative stuff that you hear in the press, in newspapers, in gossip around the rooms or wherever, is they have Narcan parties so they can wake each other up. So that's what it's being used for. So we can all have a party and somebody stays a little bit cleaner so they can revive all of us. And those are the kind of things that aren't served unless we're just shouting from the rooftops. Are you with me? I mean, unless we're shouting from the rooftops. That type of stigma, misunderstanding, and negative concept is what we can only do by shouting from the rooftops, because they're going to remember that, reading that in the paper, then all the positive stuff that you just so greatly expressed right there,
I think
Sorry,
that to the point of the parties and people just using it, I think we have to remember too that getting opioid reversal is not pleasant. And so
Right.
many people are not seeking that out. And so it's just kind of, it's just that stigmatizing language and message. And yeah.
For
And
sure.
I think
For
it's,
sure.
but here's the other thing. Isn't it a fair question? And I'm not endorsing that. And I don't believe that that's a thing that happens. I think that's the smallest amount of Narcan use is that. But okay, let's just say that happens, right? Isn't it still good to save a life? Like, don't we want to save a life? If the opposite of that is death, like, then isn't it still better that somebody's life is saved?
Absolutely. Absolutely. It's just unfortunately us, we hear negative and we remember negative. Positive stuff, we, drops on the floor like a rock. But you still have right now, today, many police officers and stations throughout whatever county you want to look at that are not mandated nor and refuse to carry it. And that's your choice. I mean, that's your choice. So again, regarding pandemic, I don't know whether that helped or hurt for us to just, helped or hurt for us to just keep pushing and reaching out to law enforcement and first responders, the need and the necessity to have that life-saving tool.
Yeah. And I think part of that is elevating positive examples, right? So for example, we had the RTA police come to Stella Maris and talk to us, and we had a great conversation with them about what they're doing around harm reduction, around helping, around driving, people towards treatment, making sure that they have naloxone. It was a really great example of best practice, right? So like they sat down and they talked to us about best practice. And so then it's kind of like, to me, then I go, okay, here's a great example. How do I get you in front of maybe departments that for one reason or another aren't aware of that best practice or are not executing that, right? So how do we elevate those best practices? Because I think you're right. I think sometimes it's easy, including us, right, to focus on all of the negative things that are happening when we all need to be really conscious of like all the great things that are happening, find those things and then elevate them up. I do want to be mindful of time. We have 5 minutes left. So what I would ask you is if you could each maybe give me kind of a 1-minute recap of what you want to leave us with, leave the audience with after this conversation. And we're going to go around in the order of my screen. So I'll start with you, Kimberly.
Oh, with me?
Yep. You're
Oh Lord. I don't know. This has been great, by the way, and I was very nervous, and I'm honored and glad that I got on. I think we just need to, as a whole, and this is going to sound like some bad country song, but just join together in the conversation that we have here is to just reunite, and we need to pull out of this. We need to not. I think it's become a tad bit habit forming to do things on a computer, a tad bit habit forming to take a meeting on the computer when you could go face to face. And I don't think the OUD crisis as a whole is going to be served if we've gotten too used to not moving our boots. And that's it. That's it. Thank you guys for letting me come. I really appreciate it. Okay, Chris, you say something really good.
Oh no, that's pretty hard to top. I do agree. One of my favorite recent books is by a guy who really changed the way that I look at addiction. So the name of the book is Chasing the Scream. It's by Johann Hari. And he basically said that the opposite of addiction isn't sobriety. The opposite of addiction is connection. So if we're going to beat this thing to the extent that we stay connected, keep connected, and keep reaching out to people that are in trouble and people that need help, that is our way out. And so, yes, little things we can do, big things we can do, but we all have to sort of stay connected and try to stay on the same page with evidence-based practices and best practices. So I guess that's what I would say. And then my other favorite little saying is from sort of the Narcan world, which is you can't treat a patient that's dead. So we need to at least start with the baseline of keeping people alive so that we can get them started on their recovery journey. So I guess that's what I would end with. So thanks again. This has been great.
Thank you.
All right. Now I have to follow quotes. So I would say looking at the pandemic and how it's affected, OUD treatment, I think, like we've said throughout, there's a lot of double-edged swords. But I think now we're in a place where we can finally just think of what we call at my agency our COVID Forever plan. And so just the idea that, it's going to be around a while. So we need to start preparing and looking at that. And how are we going to continue to keep our doors open, allow patients to come in and get the treatment they need. And so just being mindful of that, overall, we are doing a much better, I feel more prepared now than 2 years ago when we were sent home overnight. And so if, there is an increase in a surge again and we have to back down a little bit, I think we're able to still have patients come in safely and being around each other, which is good. So groups can continue and stuff like that. That's all I really have. Keep Narcan around. And thanks. This was fun. Thank you.
Thank you. Well, I want to thank you all for such an engaging conversation. I personally really enjoyed it, and I would imagine that everybody in the audience got a ton out of it. So I'd also like to thank everyone who was here listening live, and anybody who's going to listen to the recording in the future. We'd love your feedback, so feel free to reach out. I believe there's some you have the ability to provide feedback, so we'd really appreciate it. And again, thanks for joining. It was the Epidemic Within the Pandemic, Evolution of the Crisis. And I want to thank the Northeast Ohio Opioid Consortium for putting this on. And we are at a perfect 59 minutes and 57 seconds. So we will go ahead and end it, and have a great evening, everybody.